Welcome everybody to this event today. I'm really looking forward to it. My name's Steph. I'm the head of the Scottish AI Alliance, and this event is in partnership with DHI Scotland, which is the Digital Health Innovation Centre. Got that right? Institute. Today I have with me two fantastic speakers to kind of talk you through the right decision support service and the use of AI in it. I'm really looking forward to it because I kind of have a bit of background in healthcare, but also it's really interesting because the use of AI in this context is quite often not the most commonly talked about use of AI in healthcare, and because AI and its use in, say, radiology and pathology are usually dominate the discussions, which is great because obviously lots of amazing stuff is being done in that field. But it's really good to hear a slightly different application of AI in supporting and improving healthcare for all in Scotland. So today I have with me, I'm just going to quickly introduce our guests. Jeanette Hughes, who is the Director of Performance and Planning at DHI, and also Dr. Anne Wales, who's the Program Director for Knowledge and Decision Support. So I'm going to hand over to Jeanette to do a bit of scene setting, and then Anne will talk us through the service itself. So over to you, Jeanette.
Yeah, thanks, Steph, and it's so nice to see everybody, and so nice to see in the chat lots of different jurisdictions and regions across the UK coming into this session. As Steph said, my name's Jeanette Hughes. I'm Director of Planning and Performance for the Digital Health and Care Innovation Centre. So like Steph's organisation, we are an innovation centre that's funded by Scottish Funding Council and Scottish Government, and we're very much demand-led. So that's one of the key points. We look at where the needs are and how we use innovation, technology, digital to enhance efficiency, build capacity and capability within the system, and really to transform services for health and social care. So we can't ever forget our social care colleagues who, our patients don't see any boundary between health and social care. So that's an important point to make. And I know that Anne's work doesn't just look at health for the right decision service, but also looks at the social care elements and how that can be applied. So that was just one key point. So delighted to be here. If I can move on to the next slide, Anne. I suppose the point, and this slide is actually coming through from our emerging trends report that we're about to launch in the next 3 months. But it really, I suppose, highlights the amount of innovation that's came through over the last 10 to 15 years. And, AI is in amongst that. It's positioned here as being something that was introduced in 2016, but I suppose, as everybody knows, it's been here a lot longer than that. The thing that DHI is most interested in is how do you apply AI to actually make difference to service, and how do you actually scale AI within that transformation? And one element for us that I think is key to point out, it's not just about the AI innovation, it's about the service innovation and how you actually embed it within the service so that people are confident and comfortable that it can be used. And I know Anne will talk a lot more about how that's happened within the right decision service and platform that she's scaling in Scotland. So if I can just maybe move on to the next slide, Anne.
Sorry, Annette, but Jeanette, was there more than one slide you wanted inserted?
No, that was it. I just wanted to introduce the next slide for yourself.
All right, thank you.
Yes. So Anne's now I'm going to pass over to Anne really just to talk about decision support. But I suppose before I do that, what we're seeing just now with digital health and care is the drive to scale innovation. And that's key. Obviously, COVID, we in reflection actually did assist the scale up of a lot of innovations. We helped scale up the COVID apps that were used for the population. But generally it is still taking a long time to get an innovation to scale, even though some of the challenges and the main needs and drivers remain the same. So I would say that that's one of the biggest challenges, and Anne's done very well, and she'll probably talk a wee bit about the potted history of how to get something to scale. But what I would say is it's not the easiest thing to do, and the reason for that is the evidence and the amount of stakeholders that you need to take on that journey to make sure that they are comfortable, confident, and they actually have the budget to move it to scale. And it's not just about getting to scale for us now, it's about actually having it sustained within the services for the benefit of the populations that you're all dealing with, and also for the benefit of embedding this where efficiencies can be found within the service and the system. So I'm going to now hand over to Anne, who will start taking you through some of the slides, and I'll punctuate it by some of the Q&A piece at the end of each section. Over to you, Anne.
Thank you so much, Jeanette. So building on the challenges around embedding at scale and pace that Jeanette has been talking about, the question for the decision support programme is around why we need to embed decision support at scale now, absolutely at this time. And the reason it's so important to achieve that adoption at scale and pace just now is that decision support offers some really valuable solutions to the major sustainability challenges facing health and care services currently. So we know, for example, that demand for our services is growing at 4.5% per annum. Only 10% of that is due to the ageing population. Much of the increase in demand is due to choices made by our staff and by our citizens. We also know from international data that on average, 30% of the care that's delivered in the developed world is some form of waste or low value, and 10% is actual harm. So clearly we need to get better at delivering best value healthcare, as the term is now. And that means making decisions that ensure the best use of the limited resource that we have, and that deliver safe and effective care based on outcomes that matter to people. We had a review carried out in 2021 by the Faculty of Clinical Informatics, which confirmed that decision support can really help in addressing some of these critical challenges around service sustainability, and gave a strong voice from clinicians in particular that it is needed now to address the unwarranted variation in practice that leads to overuse of treatments and tests, but also to address underuse of services by inequalities groups, to involve people in shared decision making so that decisions are based on outcomes that matter to them, so deliver value in that sense, and also to apply decision support to help deliver new transformative models of care, for example, within the care and well-being portfolio, which is all about moving beyond treatment in hospital settings to supporting empowerment of citizens in communities and focusing more and more on well-being and prevention to help manage that demand capacity balance. So the challenge that we have in the decision support programme is about adoption of decision support at pace and at scale to address these very immediate and urgent pressures facing our health and care services. The key vehicle that we use to help deliver on that challenge, funded by Scottish Government and specifically funded to achieve national scale up over the next 3 years, is this Right Decision Service, Once for Scotland decision support platform. This provides two sets of tools. One is a knowledge translation tool set that converts validated guidelines and consensus based on best practice and experience and validated research into computerized knowledge formats. Often that takes the form of algorithms or rules that guide the user through a decision tree to the appropriate outcome for the particular patient they're supporting. But it can take some other forms as well. For example, shared decision aids that provide visual information to support shared decision making between the citizen and the healthcare professional. The computerized knowledge elements that are delivered through these knowledge translation tools sit in a single repository where they're packaged up and published in different forms, firstly as standalone web and mobile apps, but also integrated with electronic health record systems. So the delivery model for rapid spread that's grown up around this right decision service has a number of key elements. Firstly, it's based on a robust and extensible national platform. And just as importantly, it's a distributed model. So rather than having a dependency on all developments being carried out by a centralized team, we have decision support leads and we have knowledge managers based in most boards that use a number of these knowledge translation and publication tools on a self-service basis. So a key aspect of the model that's enabled a good delivery at scale up to this point is the fact that we are able to use existing resource, existing staff, principally knowledge managers across the health boards who use these tools themselves. There is no need for them to commission a costly programming and software expertise to deliver many of the tools I'm going to show you today. And another key element of achieving this spread at pace is the fact we have this shared repository of tools and content that can be reused across different applications. Closely related to that is the fact that the tools we deliver are based on validated evidence, and they're delivered through technology that's already in day-to-day use in health and care. So validated evidence is really key to acceptance and uptake within the clinical community and to a large extent in social care as well. And of course, delivery through day-to-day technology helps to embed these tools at scale within existing systems. So we deliver through web and mobile apps that are already widely used across the system, and we deliver through integration with care record systems. And here are the types of tools that we primarily focus on for delivery at scale: evidence-based guidance and pathways, calculators and risk prediction tools based on existing validated research, and tools delivering algorithms that are built by people, and those algorithms are based on validated research. We do have a couple of projects more at the R&D stage that are delivering algorithms generated by computers through machine learning specifically. But for delivery at scale, it's these other forms of decision support that have achieved greatest traction. So I'll pause there just to hand back to Annette for any comments or input from the participants today around your experience of accelerating scale up of innovation.
Yeah, thanks, Anne. I think there was a few questions that were appearing in the chat. One specific one, Anne, was the connection to TURAS with NES. Can you explain how that works?
If you mean TURAS as the learning platform, then we can, and in some cases do, provide links from the TURAS learning platform to the web-based applications that we build. For example, currently we're working on our realistic medicine national app that will be delivered in web and mobile format, and as well as tools and resources to support day-to-day practice. That app will embed educational resources that have been put together by NES, and that web-based app for realistic medicine will be signposted from TURAS.
Yep, thanks, Anne. I suppose then I'm just trying to see if there's any other specific questions, but I suppose, Anne, what you're asking for a discussion perspective is really the people on the call to share some of their experience and whether they've seen and how they've seen the scale up of AI innovations. So anybody brave enough to put their mic off and give us some examples, maybe from your jurisdiction, about how this has maybe been used and how AI.
There's a few hands up. I'm not sure if you can.
Oh,
see
is there? I'm not seeing the hands. Sorry,
okay.
Steph, if you could maybe.
Yeah, no worries. But can I just quickly, before we go to the hands, there's a couple more questions that come.
Oh, is it right? Okay, let me just see the questions. So, Anne, there's a question from Kevin, model for decision support being used in other domains already, or is it based on how this has been done in other domains? So, Kevin, I don't know if I've actually asked your question. Do you want to come off mic and maybe ask Anne your specific question, if possible?
Kevin.
Yeah, I'm not sure if maybe Kevin.
Oh, there he is.
Sorry, it took me 10 minutes to figure out how to do that.
That's all right.
Well, it was just whether the architecture gone from AI research on the one side right through to apps and practitioners on the other side was based on how that's been done in other domains. Really, that's all, and whether it's a new approach. And the reason I'm asking, which I guess is worthwhile sticking in here, is because we're based in Aberdeen doing research looking at human AI interaction and barriers to machine learning based devices being persuasive because of bias within those systems. And to do that, we're going to need to build an HCI platform. So it's not in the health domain. It's basically more research, I suppose. So I'm interested in how this particular way of doing it
could translates,
or even if it has been tried in other domains.
So thank you. It's a really good question. So we are fortunate in healthcare that we have this strong emphasis on using existing evidence, to inform any development. So we did have a rapid systematic review carried out by the knowledge management team at Healthcare Improvement Scotland to identify key features of decision support tools and platforms that enabled a high impact and greatest likelihood of success. So we've absolutely built, on the recommendations from that rapid review. We've also engaged with a network. I don't know if others on the call might be aware of it. It's an international network called the mobilising computerised biomedical knowledge network. Sorry, it's so long-winded. It's called MCBK for short. It's led by real kind of thought leaders in decision support internationally, principally from the US and the UK. And they have a number of key principles that they recommend around building decision support systems and the standards that should inform those systems. So we also made extensive use of that expert knowledge to inform our development. And indeed, the review that was carried out by the Faculty of Clinical Informatics acknowledged, well, more than acknowledged it praised, I guess, the fact that we had made use of existing best practice. Having said that, there's also many aspects of this that have evolved, you know, from our initial early innovations, testing out different approaches and landing on what actually works best. And I'm sure that there'll be that ongoing evolution for much longer to come.
Thanks, Anne.
Outside this to send you details of that MCBK network if that's of interest.
Yeah, I thought, Anne, we could maybe put it in the chat as we go through the presentation, and Steph could send it out perhaps later. Sandy, could I ask you to come off of mic and just to ask your specific question? I think it's always better to get the question from the horse's mouth rather than me trying to translate it in the chat.
No problem. Yeah, I'm from Northern Ireland. Yeah, so I was interested how you have done any knowledge translation work in fluid prescribing in the acute care sector, because that's quite a hot topic.
Oh, it is, yes. And we actually have got approval in principle from the Scottish Government to use the Right Decision Service to deliver a national IV fluid prescribing calculator, having been through a fairly lengthy process of getting consensus across the boards on how that calculator should be constructed. We're just going through what are hopefully the final throes of information governance and clinical governance approval from the lead organisation concerned. So that you're absolutely right, that is a key hot topic area, known to be a key source of clinical error, and one we're committed to supporting, and hopefully we'll be able to very soon. Happy to pick that one up with you offline as well.
And Sandy, we're doing quite a lot of work with Ireland, Northern Ireland and the Republic. So perhaps, you know, in one of our visits, depending on where you sit within the Irish ecosystem, we can maybe get together to talk about decision support tools in a bit more detail. Julie, you have got a question about the evidence. Do you want to come in at this point just to put your question across?
Hello.
Hi.
Hi, I'm from Healthcare Improvement Scotland, so I've got a question about the evidence side of things, and I've just recently heard about this, so excuse me if I'm being naive about it, but my understanding is that different types of evidence like sign guidelines and protocols and pathways will all sit in the one place, and I'm just wondering, how does anybody maintain that to make sure that there's nothing contradictory in the evidence and it's all been kept up to date?
Yes, so that's really where the devolved and distributed model comes into play. So our preferred model is that the organisations that provide the guidance, so in the case of SIGN, it would be SIGN and Healthcare Improvement Scotland, we give them access to the knowledge translation tools so that they can maintain and update the content themselves. There's a few cases where, for capacity reasons, the provider organisation says it's not able to do that, and then we reach an agreement whereby the national team will carry out updates within an agreed timescale.
Okay.
The longer term, what we really want to move to as far as possible is using the Right Decision Service as the primary publication route for many local and national guidelines, rather than having them delivered as PDF documents and then we need to do this translation to get them into the mobile and web format. But that's my kind of medium term goal.
I wonder again, Anne, if you could follow up with Julie with his conversation. I'm just aware people's hands are up, so I've tried to, Steph, thank you for pointing that out. Can I go to John? So John, thank you for your patience. Can I bring you in to ask your question?
It wasn't a question, it was really kind of a response to the questions posted about how to accelerate and scale these initiatives. I guess I'm coming from it from, I'm a project manager with ICAD, so our program is around doing machine learning for healthcare. It's Innovate UK sponsored.
Yeah.
And the aim here really has been, what we found is the way to accelerate is actually a good collaborative work between the two NHS boards that we work with closely, which is in GG&C and Grampian. The academic institutions that are there as well, so Clark University and Aberdeen, although we do work closely with Edinburgh as well. We do have some of our project work based there as well. And also industry. So I know you've heard it, that the triple helix has been done to death. But really that's what's been key, and it is getting all those partners working together to try and accelerate it. I mean, the biggest difficulty that we've had is access to data. Because we're machine learning based, we need large quantities of healthcare data, and obviously there's nervousness about the various ethics committees and data controllers from releasing that data. So that there is still a lot of work to be done UK-wide, not just in Scotland, to try and standardize some way. Because you go to one ethics committee in one location, they'll say one thing. You go to another ethics committee and they'll say another thing. So I think if you're thinking about looking at machine learning that doesn't require lots of data, that's something you need to account for in your planning.
No, thanks, John. That's, I think, a great observation and shared experience. And certainly at the Digital Health and Care Innovation Centre, we see pretty long delays when it comes to sharing of data, whether it's between two health boards or projects. And I know that there's conversations probably at the highest levels about actually how can we smooth that a little more. Because again, going back to COVID times, it was remarkable what we achieved in short order, because actually we were working together. There was a much more central approach. So I think there's definitely lessons to be learned from COVID, and actually how information governance and data sharing can be accelerated for the purposes of research and scale up. So no, point taken, no silver bullet identified as yet, but I think everybody's aware that that's a key barrier that needs to be either removed or eroded a little to make it easier. So no, that's a really good point. Can I go to Claire? Because I think, Claire, you've been waiting patiently in the sidelines.
Hi, can you hear me okay?
Yes.
Yeah, hi, I'm a lecturer and a PhD student in Glasgow Caledonian University. And I was first involved in CDS for radiology in the RCR iRefer and MedCurrent embedded into our radiology referral systems for probably about 2 or 3 years when the Scottish Radiology Transformation Project took that on. The Scottish Radiology Transformation Project have now handed that back over to the trusts, and basically I've been trying to evaluate the project for the last 2 years, and now I'm really just hoping that I can network with you, and that's really a plea to you to try and improve my networks back over to GG&C, because without the Scottish Radiology Transformation Project, I have kind of hit a barrier of the project even starting. I have got data, managed to get data. John's last comment, we got our pre-evaluation data into Safe Haven, which took a bit of time, and that was fine. But my immediate barrier now is I don't even know if the project's been shelved or where it's sitting on GGC strategy. And I was kind of hoping I could just reach out to you offline if you are able to offer me any advice or network opportunities to get things going again, please.
Yeah.
I'd be very happy to follow up, and it sounds like John would be a really important contact for you as well. Thank you, Claire.
Okay,
Yeah.
I'll give you some email.
Thank you.
Yeah, that would be good. Thanks, Claire. Steph, I'm aware of the time, so I just don't want to go too far down, but I think there's a really good question. I think everybody's hands have been dealt with, but Christina, you were asking just for a bit more explanation around the patient-generated algorithms and the data. So Anne, could you maybe answer that one? I don't know if you've seen it in the chat, and maybe I'll let Christina frame the question.
Hi, this is Christina from the United States, and I was just curious to understand, are you using unstructured data, or what do you mean by patient-generated algorithms? I guess I'm most familiar with using data science and machine learning, so this was a new topic for me.
Right. I think that's maybe a miscommunication or misunderstanding. We don't use patient-generated algorithms as such. We do have algorithms based on validated research that are used to support self-management and decision support tools for patients. So maybe that's where the misunderstanding has come in. So we have algorithms that support patient decision making, but the data that drives those algorithms isn't directly generated by the citizens. Having said that, some of the tools that we deliver in that way, for example, we have a dementia wellbeing app that enables people who've been recently diagnosed with dementia and their carers to keep a dementia wellbeing diary where they map their outcomes or score themselves against 5 key wellbeing outcome areas, and they can see how that pattern of wellbeing is changing over time. That gives them and their carers and healthcare professionals useful information about when more support might be needed. And there's some support resources built into the app, but it also highlights when it's recommended they might seek healthcare professional support. So that's an example of data being generated by patients or citizens through an app that's based on algorithms which are themselves founded in research, in this case the WHO research around patient-centered outcomes in dementia. So
Okay, that is helpful. Thank you for that context and background. So you're using patient-reported outcomes data,
yes,
and running it through. Okay, thank you.
I think it's probably wise to move on now, Steph, if you're happy, and Anne, if you're happy. I think most of the questions have been catered for, and Anne, I know that you'll be sharing the slides later, and I would probably urge you to answer the questions in the chat just as a round robin for Steph to maybe distribute in case people have had to drop off. So over to yourself.
Yeah, sorry, and just a quick thing, there is a question in the chat from someone who had to drop off. She's looking forward to seeing the answer in the recording afterwards. So we'll come back to that at the end. And I realize you still have quite a bit to go.
I'll just do the one case study. If
that'll be amazing. Thank you.
Yes, no problem. So great to have all that discussion. I've just got one case study that illustrates use of decision support tools created by our platform to address some of the challenges mentioned earlier on. This is high-risk prescribing decision support embedded in primary care electronic health records. Challenge here is the high proportion of emergency hospital admissions that are due to harm from medicines. They're one of the biggest reasons for emergency admissions. Over 70% of those are due to older people taking multiple medicines, and an amazing 50% are estimated to be preventable. So there's a very clear and urgent need for scalable interventions that improve management of polypharmacy. What we've managed to do with the Right Decision Service platform is convert 68 recommendations in our national polypharmacy prescribing guidance into algorithms that sit on the Right Decision Service platform. As soon as the clinician opens a patient record, so this is a patient record being opened in one of our primary care electronic health record systems, as soon as that patient record is opened, the Right Decision Service platform algorithms are triggered. If any high-risk prescribing issues are detected in that patient record, then these alerts are issued. As you can see, these are not simple drug-drug interaction alerts. These take into account changes in patient physiology and biochemistry, as well as age, gender, and condition, and how these things interact with medicines. The clinician can open up any alert to see the nature of the risk and the recommendations for action. You are able to suppress the alert for an individual patient for up to 12 months. Given that these are very complex patients, sometimes a shared decision is reached that actually this prescribing regime overall is beneficial for patient and the benefits outweigh the risks. They can also record their action in the decision support window and save that back to the patient record. We piloted this initially in 2 health boards with very positive results, actually more positive than I was expecting. They found that it really did identify significant clinical risk that they wouldn't otherwise have detected. All wanted to continue using it and could see important scenarios where it would be really useful. The great majority found it user-friendly. A few examples of the kinds of risks that were picked up. So they were really quite, some of these are really quite significant patient safety risks. We, on the basis of that pilot, we've now been able to make real progress with scale up. With the 2 initial pilot boards have approved board-wide rollout. Forth Valley and Glasgow have agreed to initial pilots with a view to then achieving board-wide rollout. And we have a proposal in place with Dumfries and Galloway. I'll switch very briefly now to one of the clinicians involved in the pilot, just so that you can hear in his own words the value that he and his colleagues place on this tool. So, Scott, can you tell us what happens when you open a patient record that has some high-risk prescribing issues?
Of course, what will happen is I will be opening the record as normal when a patient attends for a review or I'm doing something in the notes. And as I click to open the record, automatically the decision support tool will alert in front of me. Some people might be concerned about over alerting. That isn't the case with this tool. This tool has had triggers that are specifically chosen by clinicians and has been assessed and piloted to only bring up the most relevant high risk triggers. Not only that, but these triggers are relevant to the specific patient. For example, it might have checked a previous renal function or documented blood pressures and only be triggering because of the coded data that's in that specific record. Patient might be coming in with atrial fibrillation. They are not on an anticoagulant, and it might alert me to say this person has coded atrial fibrillation, is not an anticoagulation. Sometimes that might not be relevant. I'll look at the notes and say, actually, that's good to know, but actually, I can see a previous documented discussion about that, and that's not something that we're doing anything about for a specific reason. But equally, it might be that the person's now older and it is now relevant that we have that discussion again. I find them really helpful. I find them supportive, and they're not intrusive. It's really easy to minimize it and move on with my consulting. But equally, the things that come up tend to be things that I want to know about going into the consultation. No triggering system is perfect, but it's nothing like the triggering systems I've ever used before.
Brilliant. And do you want to go back to your slides for the last?
That was really the last part of that segment. So happy to move on to the discussion.
What happens when you open a patient record that has some high?
I think you still have the sound running.
I think it's always the joy of video. You then play it and then you don't want it to play and then it plays when you do, vice versa. So yeah, I think you still get video.
I'm really sorry about that.
That's all right. It's all right, Anne.
So I just had a question to start off the discussion. That's the link to the video, so we can follow up later. Interested. So just so yes, these were the questions I thought might be of interest to the group.
Okay, Anne, thank you. Kirsty, you've got a question that's appeared in the chat. Do you want to come off mute and just ask Anne?
Hello, Anne. I find the concept really exciting that the decision support tool would pop up, and I just wondered what the challenges you've found so far in integrating this with clinical systems, and yeah, just really the main issues with that. Is it something that I could dream about in the near future, or is it too complicated?
Good question, Kirsty. And Anne looks very happy, but she's been through the wars a lot of the time with trying to integrate systems. So Anne, I'll pass over to you to field that.
Yes, yeah, thanks very much, Kirsty. So you're right that it was not straightforward. Some of the challenges are around the fact that most of the systems currently in active use in Scotland don't currently comply with standards for sharing and messaging data. That would make it easier for us to interact with those systems. So Vision and EMIS in primary care, for example, don't currently support fire messaging even. Furthermore, these systems are actually desktop client-based systems. They're not even web-based systems at present. So that was quite a major issue. We'd rather assumed that all systems just now would be web-based and lend themselves to web-based APIs, but that was not the case. The third challenge was more operational, really. These big vendors for the whole country already have a huge backlog of developments they're committed to for NHS Scotland, and trying to get any slot in their development cycle for integration work needed on their side was very difficult, and needed a lot of clinical authorization and support. We addressed that, to be honest, quite largely by absolutely minimizing the requirement for any technical work on their side and taking on as much as possible for proactive delivery through our platform.
Yeah, I think another point, and just to add more generally from a digital health and care perspective, when you're doing innovation, is to try and involve the e-health colleagues or the IT people within legacy systems early, even if it isn't you're asking them to do anything, but to take them on the journey so that they know that maybe 6 months, 12 months from now, there could be a backlog item about an integration that would allow the service and system to work better. We're certainly finding that across the board, and we try to bring them in as early as possible without wasting their time, of course. And especially when it gets to a kind of a state of readiness where people are encouraged by the evidence and the results that it could really make a difference, and you actually want to move it into adoption, spread, business as usual and scale. It's really about the planning around that to make sure that you don't end up at the end with a year's delay because actually nobody told eHealth that I had to integrate with something else. So I think it's a wee bit about the planning and the involvement in the kind of wider community that can actually make scale happen. So that would be kind of a key point just generally for anybody that's doing innovation in this field. Hope that helps, Kirsty. Kevin, you've got your hand up.
Yeah, it was, I don't know if it's too low level a question, but it is related to how easily something that we might develop in Aberdeen, how easily it could be scaled up. It's about this, it's basically about the software engineering that the AI development is done within. So for example, there's this TensorFlow package that Google has, which provides for all sorts of off-the-shelf models and various software engineering practices, all the way through to the development of an API. Mm-hmm. And then on the other side of that API then allows you to create the actual applications that access the AI. I was just wondering whether you guys had any recommendations or directions or nudges towards working at that level within particular software engineering schemes or packages that would facilitate the scale up, you know, from day one, basically. My computer science collaborators here in Aberdeen are just either we can work like cowboys or we can actually engineer this properly. So would there be particular software engineering practices that we really should be embedding right from day one?
Yeah, that's a great question, Kevin. Anne, I can see your post to answer.
Well, it won't be a full answer, Kevin. I think it's probably something it's best to follow up with the actual technical team that delivered the platform itself. But what I can share, in fact, I maybe will share my screen if time still allows, is this little image here, which might give you some insights, and we can discuss it further, you know, in a follow-up call if that's of interest. So we develop our decision support algorithms using some bespoke development, quite a lot of bespoke development, but also two key standards, the guideline definition language and clinical quality language, that both require engines and processing to deliver them. A key part of the architecture, as you've indicated, is having a managed API that enables these algorithms and engines to interact with data that is messaged through from the clinical systems. It does require those clinical systems to provide the data in a particular format, even if they don't have the full file compliant interfaces. At least if they can provide a message in a basic file format, we can interact with it. And then, as you've said, you can build applications like your mobile apps on top of this that can use the API to interact with the algorithms. So I think there's some similarities to my non-technical understanding, some similarities with what you described there, but I and the technical team would be very happy to discuss that more fully with you.
Okay, thank you.
Yeah,
That does
thank
look very
you.
similar to other schemes I've seen. Yeah, thank you.
Yeah, thank you, Kevin, for the question. John, your hand's up.
Yeah, it was really just as a kind of a response to what Kevin was asking. I was going to just recommend, I've put it in the chat as well, that that Kevin, if you're University of Aberdeen based, then it might be worth to dash the safe haven, because there's ICAD instigated work that is building a FHIR interface to get data out of the systems there. So that might be of help. And I guess what we do within ICAD is have an environment embedded within the safe haven that allows you to import your workspace essentially. So it's container based, if you want to get technical. So you can bring your own tool set within that environment, and then you're restricted in terms of, you've got data that only you can access and use for your machine learning. And I think that's if everyone, I don't know if everyone's familiar with the Goldacre report that was released very recently, that there is a push UK-wide to go with what used to be called trusted research environments, but now are called secure data environments for doing this type of work. And I think that's kind of, we've had it in Scotland for a while, so we've been ahead of the game on that one with the safe havens, and it's really making sure that we continue to on that sort of trajectory.
Yeah, no, that's a good point. And I suppose innovation centres like Data Lab and DHI have stood up, sandboxes to make sure that interoperability piece is catered for, and we de-risk the same as the safe havens are. So yeah, I think we are still ahead of the game, but we could always keep moving and keep pioneering. Steph, do you want to take over? I can see your hands up.
Yes, yeah, thanks. No, before I wrap up, this has been a great discussion, and I think what might be quite nice is I'll suggest to Anne and Jeanette that perhaps we follow up with a wee blog from them, that we can include the recording from this, as well as perhaps all the answers, all the questions that may not have been answered, and have you guys answer that, which would be really great. But I quite like to bring up the question that Mel dropped into the chat before she signed off, because in the spirit of the Scottish AI Alliance and our vision around trustworthy, ethical, and inclusive AI, she did ask, what tools and processes do you use to understand the 10% harm for those impacted by automation? I imagine the types of harms will be different across different areas, even if it is the same automation. That's quite an interesting question. I don't know if you can answer it, but it'd be great to hear your thoughts.
And you want to?
Yes, so the harm that was referred to in that first slide is actually harm that results from clinical error in decision making when it's not supported by mechanisms like decision support based on best evidence or other types of support that mitigate against the likelihood of harm. So it's not the case that harm is caused by automation. This is harm that's inbuilt, into the way that health and care services work just now, where there's always the potential for clinical error, and the important role of decision support and other safety methods is to help reduce that likelihood of harm. We are still, there's a growing body of research around how effective decision support is in mitigating against these risks. It does vary according to the nature of the risk and the condition and the outcome of interest, but there certainly is a clear consensus that it can have really significant impact.
That's brilliant. Thank you very much. And it would be remiss of me to not mention also that we're currently in the process of the development of the Scottish AI Playbook, which is kind of an open and practical guide to AI in Scotland. We've launched the beta, which is currently a wiki, and we're very keen to obviously have a healthcare zone in it, a health and social care zone. And you know, we'll obviously be hopefully working with you guys, DHI, you know, the Right Decision Support Service, iCared, the NHS AI Hub that's currently in development as well, to make sure that we have the kind of, we're signposting to all the relevant, you know, resources and toolkits and all these services and all these key learnings, so that anyone can just go in and go, aha, cool, DHI have done that, NHS Grampian have done that, iCared have done that, so you can all learn from each other. So well, we're bang on in the hour. Some people have had to drop off, but general thing is everyone said thank you so much for your presentation, Anne, and thank you so much, Jeanette, for kind of keeping it all together. And we've got an applause, which is fantastic. So thank you so much, everyone, for attending. What we'll do is we'll immediately follow up with the slides and Jeanette and Anne's contact details. John, I don't know if you want us to include your contact details too, just to make sure that people are aware of iCared and can get in touch too.
Yeah, sure. Just drop it in the chat.
Yep. Okay. Yep. That, and we'll put that in the email out with the slides, and then we'll follow up with you, Anne and Jeanette, about putting all this into a blog and answering some of those questions in the chat that we didn't get around to. But otherwise, thank you so much, everyone.
Yeah, thank you
for coming.
Thank you, Steph. Thank you, and thanks everyone for your interest in all the questions and discussion. It's been great. Thank you.
Fantastic. Have a great week, everybody.
Thank you, guys. See you later. Bye-bye.
Bye.